So we presented on the GRIFFIN study here at IMW 2019. So GRIFFIN is a randomized phase 2 study looking at incorporation of daratumumab into the lenalidomide, bortezomib, dexamethasone backbone for patients with transplant-eligible multiple myeloma, newly diagnosed. So last year at ASH, we had presented on the 16-patient safety run-in of the GRIFFIN trial, and what we had showed at that point was that the addition of daratumumab into the RVD backbone in the transplant patient population was safe, didn't seem to have any clear impact on stem cell mobilization and engraftment, and we saw very promising early responses in that particular group of patients. So the phase 2 portion of the study is a randomized phase 2 study where patients got 4 cycles of RVD. They then went on to stem cell mobilization and collection with G-CSF, with or without plerixafor. They underwent a single high-dose melphalan stem cell transplant. After recovery, they got 2 cycles of RVD consolidation, and then they went on to len maintenance for 2 years, although they were allowed to continue beyond that if they were tolerating therapy and continuing to respond. Now, in the DARA arm of the trial, they got daratumumab throughout the duration of that whole treatment spectrum. So in the induction phase, they got weekly dosing of daratumumab for those first 4 cycles of RVD. In the consolidation phase after transplant, they got DARA on just day 1 of the cycle, and then with the maintenance portion of the trial, they got once every 4-week DARA dosing. The primary endpoint, we wanted an early readout, so the primary endpoint was stringent complete response after completion of consolidation post-transplant. Important secondary endpoints included MRD negativity, overall response rate, the breakdown of the responses, and obviously we're very interested in progression-free and overall survival as well as safety. So importantly, in the randomized phase 2 portion of the trial, we did meet our primary endpoint of stringent complete response. So what we saw is that the stringent complete response rate after completion of consolidation therapy was 42.4% for those that got DARA, and it was 32% for those in the standard RVD arm. When you look at overall response rate, 99% of the patients in the DARA RVD arm responded to therapy, and whether you look at it as CRs or better, VGPRs or better, the DARA portion outperformed the standard of care arm, and that also pertains to whether you were looking at the end of induction, post-transplant, post-consolidation, at any point. Importantly, we looked at MRD as well, and what we saw there is that at the end of consolidation, again, the MRD negative rate measured at the 10 to the minus 5 level of sensitivity was 44.2%, in contrast to 14.6% for those in the RVD arm of the trial. And if you looked at patients who are in complete response and MRD negative, similarly a clear advantage to the DARA arm. There was some dropout in the RVD arm during the induction portion of the trial, probably mostly due to suboptimal responses. So we wanted to look at the MRD negative rates for those patients that went on to stem cell transplant and did not pull out of the trial. And when you looked at it that way as well, there still is a very clear advantage as far as the proportion of patients achieving MRD negativity in the DARA arm of the trial. With regards to safety, thankfully there were no unexpected surprises. We saw more grade 3 and higher neutropenia on the DARA arm. We saw more grade 3 and 4 thrombocytopenia as well. There was a signal for an increased risk of infection in the DARA arm of the trial. So when you look at all infections, it was approximately 80% versus 55%. That said, when you look at grade 3 and higher infections between the 2 arms of the study, it was 17% in both arms. And when you look at something like pneumonia, for example, 10% of the patients in the DARA arm experienced pneumonia as opposed to 9% for patients on the RVD arm. We were also interested in stem cell mobilization and engraftment. So CD38 is expressed on myeloid precursor cells. We know that lenalidomide can have some impact on stem cell mobilization when it's used for a prolonged period of time in the induction phase. So we're very interested in the ability to mobilize stem cells as well as stem cell engraftment. And what we found there is that the median number of CD34 cells per kilo that were collected in the DARA arm was approximately 8 times 10 to the 6 CD34 cells per kilo. In the RVD arm, it was a little over 9, so there was a little bit of a numerical difference there, but there was not a clinically significant difference in the numbers of cells collected between the two arms of the study. We did have to use more plerixafor in the DARA arm compared to the RVD arm. And when you look at time to neutrophil engraftment, time to platelet engraftment, it was virtually the same in both arms. So I think what we've basically shown at this point is that adding DARA to RVD in a transplant context is safe. It doesn't have any clinically meaningful impact on stem cell mobilization or engraftment. We're seeing clear evidence of better depth of response. I think at this point it'll be very important to see, if that increased depth of response is sustained over the course of time and how that will translate into improvement with regards to progression-free survival.